Hi, I'm Zena Aldridge and I'm a dementia nurse consultant with Norfolk, Waveney and CCG, and this session is going to talk a bit about pain in dementia. Although this is a bit of a standalone session, it will fit in really nicely when you look at the dementia, depression and delirium session, but also distress behaviours. So really think about these sessions and how you can kind of pick and mix them and take some of the content and use it more widely. So the aims of this session are to look at how we might have some barriers in identifying pain in people with dementia and how we might be able to overcome some of those. I can't promise you I'm going to enable you to do that with everybody, but at least if we can try and change the way we view things, that might be helpful. Think about ways in identifying pain in people with dementia who have no perhaps communication skills or real difficulty in communicating, but clearly might have some discomfort. And thinking about alternative pain management strategies. So not just talking about pain medication, but what else? And again, look at those non-pharmacological and psychosocial interventions, which are in another session as well, because there might be some tips in there as well that you could use for supporting people with dementia who may have pain. So there's lots of research out there that says that pain management in dementia is really, really poor. And you might ask, why might that be? Well, often in this, particularly in the more later stages, people might have lost ability to communicate or describe their pain or be able to let people know what they're experiencing at any one time. It might be that they might not remember the pain that they experienced earlier. And what I mean by that is, for example, we might be going and doing a drug round, or we might go into a patient's house and ask them if they're in pain. And at that point in time, they might be sat in a chair quite comfortably and not have any pain. But they might not remember that actually the moment they get up from that chair and try and take a walk, their joints start to ache. You know, they really have some discomfort. And so therefore they might say no, they're not in pain. They may not get the pain relief, which is actually going to help them later down the line in the day. So I hope that makes sense, but it's really difficult, I think, when you're assessing pain to understand that people don't have necessarily pain all the time. It might be intermittent depending on the activity. The person with pain might feel unwell, they might feel uncomfortable, they may not be able to describe the pain or where it's located. I see an awful lot of times where people perhaps have really poor dental care. They've perhaps never seen a dentist in 2 or 3 years. You know, they might be wearing dentures that don't fit them, and they've perhaps got ulcers or decayed teeth, and that's really hard to articulate. But imagine having that sort of pain. I don't know about you, but I've had tooth pain and it's excruciating if it's not met. But I can go to get myself some medication and try and alleviate that pain. That person might not be able to describe it. It might be that they feel very sort of describe a generic pain somewhere, across the body, where it's really difficult again for us to identify where that pain's coming from and what the cause might be. So we need to think again around that. I sadly still hear a myth, please break this myth if you ever hear anyone say it, but there seems to still be this belief in some quarters that people with dementia don't experience pain. People with dementia, of course, experience pain. If you've had a painful condition prior to getting dementia, or you become unwell or injure yourself later on, you're going to feel pain. It doesn't go away, and I've certainly seen situations where patients have been prescribed pain relief for perhaps arthritis or something, and when they lose their ability to communicate, for some reason they don't get that pain relief anymore. Just because they're not articulating that pain doesn't mean they don't feel it, it just means that they don't know how to. So really, really do challenge anyone who says that. And I think there is this reluctance to give pain relief to older people because there's a fear that they might make them more vulnerable to falls. It might be that it causes them more harm than good because their liver might be able, not be able to secrete the pain relief medication from their system as effectively as it could when it's younger. But it's about those individual conversations about what's in the person's best interest. We know that there are some risks attached to some medications, but it's balancing up about the person's quality of life and how beneficial that medication is going to be to them as opposed to detrimental. And that's a conversation to be had, not just with one person, but everyone involved in that person's care. And where appropriately, the person themselves, they might be quite happy to tell you that they'd be more happy, they'll carry the risk of injuring themselves or falling as a result of pain management, as opposed to falling because they're in pain, if that makes sense. It's really important to kind of balance those two things up. To understand how to manage a person's pain, we need to think about what type of pain they might be experiencing. So the pain that I described earlier, where someone's sitting down and not experiencing pain and then they get up, is procedural pain. It means that someone is getting moved during a care task, or they might be mobilising, and that makes it more difficult for them. Please do go to the distress behaviours session as well, and the example there, whereby, for example, people may be more aggressive during, or seem to be aggressive during care interventions, because you might be moving muscles that are contracted, for example, or joints that are stiff. And of course, because it's so painful, that person might lash out. They may have acute pain because there's something else gone on that is not chronic, it's not arthritis or something like that, but they might have a dental pain, it might be a headache or a migraine. I once came across a gentleman who was actually functioning quite well in a care home. He was wandering about with his Zimmer frame, doing what he needed to do, take himself to the toilet, fairly independent. And I had a few days off and went to assess him, and he was sat in a chair and he was really, really aggressive. And everyone has said, we've checked his urine, he's fine, he hasn't got a UTI or anything. And I just happened to crouch down beside him and gently place my hand on his knee, at which point I thought he was going to jump off the chair, and jump through the ceiling. And it was then I rolled up his trouser leg and I could see that his calf was really swollen. And this gentleman clearly had a deep vein thrombosis, but he couldn't articulate that pain, and it was difficult to assess and identify. So again, it's about thinking what other things might be going on for that individual. Might be that someone's gesturing that they've got, pain in their chest. Of course, people with dementia, are maybe older. They may have other health conditions. It might be something like a heart attack. So we do need to be really, really aware of the changes that might manifest themselves so that we can identify it. Of course, it might be more obvious. It might be that someone's had a fall and you can see that after that fall that they have got an injury, whether that be visible or whether you can just see how they're mobilising differently, that might be something to have investigated. Otherwise, we've got the more chronic pain. So these are the things where patients will have had, or residents will have had, a long-standing painful condition. And as I said, that doesn't go when they get a diagnosis of dementia. It just means they might not be able to communicate it. So things that might develop as well due to the advancement of the dementia might be those contractures I talked about. And contractures are when your muscles really become quite tight and don't move so flexibly. And imagine that's quite painful if your muscles are like that for a period of time and then you start to open them up. That can be really uncomfortable. As you're unable to carry yourself and position yourself more, your posture might be affected, and that can be quite uncomfortable. I've certainly found over the period of COVID, working more from my desk at home, that I've certainly had more back and shoulder pain and neck pain as a result of sitting in a very poor position. So imagine if you're in a chair or a bed that doesn't fit your requirements, that's going to be uncomfortable. So again, we may have to alleviate the pain in some ways. And of course, those chronic conditions such as arthritis are really prevalent, particularly as people get older. So if someone can't articulate pain, what might we be looking for? So it might be that they're fidgeting, it might be that they've got repetitive movements, perhaps stroking a particular area or bracing themselves, kind of really holding bits of the body close by, trying to protect them because they feel really, really painful. Again, talking about that resistance to care. So where that might be seen as a behaviour that's challenging, that's probably a means of someone trying to communicate their distress at being in pain and someone trying to move them. It might be that someone's really confused. I don't know about you, but sometimes pain can be so overwhelming if you've experienced it that actually you can't focus on anything else. So it's really difficult to kind of do those activities of daily living that you normally would, not only because of the pain, but you just can't focus on them. So cognitively you become more impaired because you're trying to cope with this pain that's really quite intensive. It might be difficulty sleeping, and again, people might be very tearful who are not necessarily tearful. All of these subtle things that you'll see here might be real indications that someone is experiencing pain. So it's worth looking at how we can identify that more broadly. So we can't make assumptions that any of those behaviours are linked to pain. We just have to eliminate it or identify it is probably the way forward. So we do have pain assessment tools that can be used for people who don't have the ability to communicate their pain. One of the most common ones is the Abbey Pain Scale, and it enables you as a practitioner looking after someone with dementia to look at the way that they're behaving, how they're positioning themselves, their body language, to try and score it and say, well, actually, could it be that this person's in pain? Can we try some pain relief? Are they having the right pain relief? There's also the Pain Ad and the $+2. So they're all available online. If you just pop in any of those as search terms, you will be able to find the tools themselves and how they can be scored so that you can practice them. I have to say, I think the Abbey Pain tool as a starter is probably the easiest one to use, and it's quite, it doesn't take a lot of training to be able to use these skills, so you could feel confident that you'll be able to use them effectively. This is the Abbey Pain Scale, and you'll see there it looks at vocalisation. So what it means by that is there any noise coming from that person? Are they making sounds that might indicate that they are experiencing pain, such as groaning or crying? Looking at their facial expression, people might look very pinched, they might be quite taut, they might be guarding their body, all these kind of things that, we've talked about earlier in this session, but certainly within the distress behaviours session as well, about indications that there might be a problem. You've also then got the physiological changes and, the physiological and physical changes that you might see. So you might see that someone's very sweaty, they might be very flushed, that might be an indication of an infection as well as being in pain more effectively. Or you might be aware that they've got skin tears or pressure areas. I can't imagine how uncomfortable it must be to develop a pressure area and not be on pain relief, but I have seen it on several occasions. And people might have long-standing injuries, and we often see cases where patients with dementia have had falls and it's been assumed that they've been fine, and then a little bit further down the line they've got an injury that's not been picked up at that time. So it's really important. And you score that patient based on what you've seen, and it gives you an idea of whether they have no pain, whether they've got mild pain up to severe pain. It also starts to give you a choice of whether that might be something that's long-standing, whether it's new, or whether it's a new pain on top of a chronic pain. And of course, people who have long-term pain often adjust to that pain and deal with it, and then something else happens and it's that bit, perhaps a fall or a dental pain that's making it difficult for them to deal with. And different pains need different pharmacological treatments or non-pharmacological treatments to alleviate that pain that the person might be feeling. I have a bit of a personal bugbear when it comes to people with dementia, and I think anyone who's ever heard me talk about pain relief before will think, oh, here she goes again. But ultimately, it's about identifying if we think someone's in pain, not giving them PRN medication, that, as required medication. It's about doing it regularly. So again, as I said, if people can't report that pain, or they might not have pain at that time, but they're going to be in pain later on, asking the doctor to say, well, look, can we just have a trial of this being prescribed regularly? I actually did a project with a care home outside of Norfolk looking at the pain management of all the residents. And I often saw patients who were being prescribed as required medication for their pain, which wasn't being given. Not because the staff were withholding it, but like I said, when they were sat in the chair and they were asked if they were in pain, they weren't. So, you know, the staff didn't feel confident administering it. But often those patients were on what we call antipsychotic medication, which is medication that's there to modify behaviour or something to calm people down. And we did a trial where we started on basic pain relief for many of them, sort of paracetamol, having regular paracetamol, to see if actually that enabled them to manage their pain more effectively, but also reduce the need for antipsychotic medication. And it was fascinating how many people did no longer needed antipsychotic medication when their pain was more effectively managed. Again, it's about thinking how someone might engage with pain management in terms of some patients struggle with perhaps tablet forms. Do they need liquid? Do they need a patch? That all needs to be considered. And obviously, if they're refusing their pain relief regularly and you're not sure whether that's because they're not in pain or they just don't like the taste or the route of administration, speak to the GP and ask for their advice on if there's an alternative that you can use. We do need to be careful about giving people lots of medications. So we can't just keep piling on medications. We need to find out what would be the best medication for that person. That's where your pharmacists and your GPs are really important. But we also need to think about what the side effects are in terms of medication, particularly pain medication. So any pain medication that has codeine-based products in it can cause constipation, particularly in older patients. So it's really important that that's factored in, that we monitor a patient's bowels and actually think about whether they should have something to enable them to go to the toilet more appropriately. For some residents and patients, it might be more appropriate to give them gastroprotection because things like ibuprofen or what we call non-steroidal anti-inflammatory medication might cause some discomfort and damage there. So that needs to be considered. And in some patients, pain relief can cause urinary retention, so we need to monitor that as well. I don't expect you to all be experts in pain management, the different types, but it's kind of just having an awareness of what some of the issues might be, because then you might be able to start to link things up. Because what I say time and time again, particularly to social care staff, is you tend to know the patient or the resident far more than medical staff in primary care and community care might do. You're spending more time with them often, you're getting to know them in a very, very different way, you develop relationships in a different way. So you'll be able to perhaps pick up some of these changes, which might then allow the other colleagues within healthcare to pick up that these might be some of the issues that individual's facing. So it's a real collaborative approach, isn't it? We need to understand that person, which has done really well in social care, but enabling the medics to then come in and see where that fits, where appropriate. So as I said, for mild pain, paracetamol is so effective often in older people, given regularly. And if you've got a long-standing condition, having a paracetamol today and then having one 3 days down the line is not going to be helpful. It needs to be regular, it needs to be consistent. And that's why I always suggest that we do it on a regular prescription as a trial to make sure and see if it has any difference. If that's not the case, then we can look again. For moderate pain, we might go onto those codeine-based products, or we then go on to sort of the morphine-based products, possibly more at end of life, or if people have got multiple comorbid conditions that really need that strong level of pain relief. But again, this is for pharmacy and GPs to work out. It's not for social care staff to prescribe, but be aware of. And again, demonstrating using the Abbey Pain tool might be something that you can then cascade that information to the GP or pharmacist to say, I really strongly feel that this person's in pain to this degree. And that might then influence what they're prescribing, as well as the medical knowledge of that individual. But it's really important just to have a basic understanding. But of course, when we start to get into the realms of these types of medications, we do need to think about the impact on someone's cognition and, of course, balancing up the risks versus the benefits to that particular individual at that particular time. And again, I can't stand here and tell you the right answers because they will be very, very individual based on the needs of that person at that time. But we don't always have to think about medication as the only solution. It may be part of the solution, it may not be part of the solution at all. So going back to, meaningful activity, movement's really important. The more people are moving, the more the joints are moving, the more the muscles are moving, the less likely they are to get things like contractures. So again, really important to think about how we can prevent pain as well as how we can manage it. Massage, just gentle massage. I'm getting to an age where my knuckles are getting quite arthritic, and I do find that sometimes just rubbing them with a little bit of oil can just get them moving again and free them up. And so of course that can work for people as well. Using heat and cold, we know that they can be really, really beneficial. The little wheat bags can be very, very helpful in terms of alleviating pain, but also providing support, particularly if someone's got some discomfort in their neck. So again, think about that more clearly. And positioning. Some of the chairs and beds that people are asked to how they sat in their beds and chairs might be putting them at odd angles that they can't then move themselves. So think about where to support under the back, for example, under people's legs, and enabling them to feel as comfortable as they possibly can. If they need a specialist assessment, that's what physiotherapists and occupational therapists are there for. It might be that they support you with a seating assessment. Physios might be able to advise on movement that's safe because you might feel that you don't want to hurt someone if they've had a particular injury or joint problem, for example. So thinking about those sorts of opportunities as well to engage with colleagues who might be able to support you more effectively. But also thinking about distraction. Why is it tooth pain is always more uncomfortable at night? My view is it's probably because we're not distracted, we're not doing anything. I keep going on about tooth pain because I've recently had some, but ultimately what you find is that during the day you might be doing other things, so you don't focus on the pain entirely. However, at night, when you're perhaps laying in bed, you might be focused completely on the pain because there's no distraction. So think about that as an example for people with dementia as well who might be in pain. Keeping them busy might be enabling them to cope with the pain. It might not alleviate the pain or get rid of it, but what it might do is help them to cope with it more effectively. But these are some of the key messages from this session really. Is we talk about pain in the managing distress behaviour session as well. And certainly it's about recognising if someone's behaviour changed, is pain a factor? Use your Abbey pain tool, have a look, are some of those indicators that might mean that that person's in pain there? Can that person, communicate pain effectively? Can they make sure it's consistent in the way that they communicate it? Ask them, of course, first if they're in pain, and think about the language they might use as well. They might say it's sore. They might just say, it's uncomfortable. They might not use the same language, so do try and probe and find out what the person might be trying to say if they're able to. Your Abbey pain scale is really a fantastic tool to kind of focus in and see whether you can see some of those changes. But always try and advocate for patients, particularly with new pain that needs short-term pain management, or for those patients who have long-term chronic conditions that are not going to get any better. Do ask GPs and colleagues to think about prescribing that pain relief regularly, because it makes it easier in terms of the management, but also in terms of thinking about how to assess pain. If someone sat, like I said earlier, if someone sat down, it's very hard to say that they're in pain until they move, but it may put staff in compromising positions if they feel they're given pain relief at a time when someone's not in pain. So I think that's certainly something we need to advocate with our health colleagues, and you're in a prime position to be able to do that because you know your residents and the people you see very, very well. You start to see these differences in perhaps how they move and how they behave, so that you can certainly advocate on their behalf.
Our question from providers for this session is: where could I find more information on pain management options? In particular, how to recognise signs of pain?
I think there's lots of information out there about how to manage pain, and I think again it's varies in its appropriateness to the environment depending on what resources you have available to you, because I think as social care professionals it's important that you look for the non-pharmacological interventions but are supported by your health colleagues to manage the prescribing, if you like, of pain medication at different stages within a person with dementia's life, reflecting on their needs. I think for me, the best thing that social care staff can do is articulate their concerns and demonstrate that in a way that they feel represents that person particularly well. And I have to say I'm a good fan of the Abby Pain tool. I've spoken about that earlier. You know, using that, it's very simple, but what I think it does is it kind of opens up a conversation with health professionals, because I think often what happens is social care professionals know that there's a problem. They can see there's a problem, they can see there's a change, but may not necessarily know how to articulate that to healthcare professionals in a way that is then valued by healthcare professionals. So I think there's this bit where we have to start trying to speak a different language in a way, and I think what the Abby Pain tool does is encourage the staff to look at the situation differently and evidence why they think that person's in pain. It is a frustration, because I think if someone says, I think that person's in pain, then if they know them well enough, it's probably a good interpretation. But this is another way of kind of validating that in a way that, you know, a GP or a nurse can come in and say, I can see evidence that this person's in pain, I can now look at how we manage that. So I think this is a big way we have to move forward. There's a gap between health and social care in terms of how we communicate, and I think that's a big issue, and I think that's what these tools do. I don't think that it changes the way we practice, it just gives a means of communication, because what we have to remember is care within a person's home or in a residential care setting is relationship-centred care, whereby patients who are seen by doctors and nurses, it's often very medical model care. So it's about how we move that information across those different kind of forums in a way that's meaningful to both, and we make sure that we articulate the needs effectively.
Thank you for watching. If you would like more information, please visit Norfolk and Suffolk caresupport.co.uk, where you'll find further training on our learning portal. The link for this website is in the description down below.